Great. Thank you very much for the opportunity to come and present today. And I just want to recognize, wow, what a huge conference. I'm going to talk about the ethical and professional expectations of physicians. And I recognize that the audience has lots of other regulated health professions in the room. But just to say that there's a lot of alignment between what the college has said for doctors and what the College of Registered Nurses has said for nurse practitioners and nurses, as well as the College of Pharmacists for pharmacy practice. So I start with a disclaimer. Medical assistance in dying is controversial, and it certainly will be the biggest social change that I am going to experience in my regulatory lifetime. And people have been lobbying the college on various sides ever since the Carter case came through, and we always like to stop and remind people that the college does have an obligation to set ethical and professional expectations for physicians. We have a role as a regulator to interpret legislative or legal requirements for physicians, and we're not for or against medical assistance in dying. Rather, we're here to act in the public interest. The second disclaimer is an apology of sorts to the palliative care people. We appreciate that medical assistance in dying in and of itself is a controversial term, and there are many who would prefer it to be called something like hastened death or planned death. And many believe that, in fact, palliative care is really medical assistance in dying. So just to say that we are legal creatures at the end of the day, and from a college perspective, we are tracking what is in Bill C-14, and it is medical assistance in dying. And at least it's a more inclusive term beyond the Carter decision, which talked about physician-assisted dying, recognizing that it is very much a multidisciplinary team act. So just to remind everybody that we've had multiple court challenges over the years. And as you know, I think I still remember the Sue Rodriguez decision, and that was no. So February 6, 2015 was a landmark day, and it set out charter rights embedded in amendments to the criminal code, which said that citizens who were experiencing intolerable suffering had a right of access to this. Many people have asked how come we're not doing what they're doing in Quebec. And for those of you who follow jurisprudence, legislation, and law for a living, I'm sorry. But more importantly, just to say that Quebec is different. And they very much, and they framed this as a medical act. And they did that from the very, very beginning. They did not frame this as a charter right or as an amendment to their criminal code. So in fact, my counterparts in Quebec started with a discussion that said, what should we do around end-of-life care? And they amended their code of ethics. And their code of ethics, and I'm sorry, this is the English translation of the French, and it's written in a male voice, which we wouldn't do here. But it said, a physician must, when the death of a patient appears to him to be inevitable, act so that the death occurs with dignity. So their concept around physician-assisted dying or medical assistance in dying was framed as a healthcare act and not as an exemption to the criminal code. And of course, they then went on to have their own provincial government bring in Bill 52, which amended a variety of things. So Quebec is truly different, and I think it's important to remember that in the Quebec situation, death is imminent, as opposed to death is reasonably foreseeable. And Quebec is now sort of on the other side they were ahead of the game, but now they have to actually reconcile what they're doing with the new C-14. So C-14, again, these are amendments to the criminal code. And it said that basically subject to eligibility criteria, patients were allowed to access assistance in dying. There were expectations around procedural safeguards, and there was requirements for oversight and reporting. Not eligible, mature minors, a situation where the sole indication is a psychiatric disorder or in an advance directive. However, the criminal code provision still exists, so it's still an offense to assist somebody in dying if, in fact, they don't meet the eligibility criteria. The criteria are that an individual has to be eligible to receive publicly funded healthcare services, and this was explicitly so that Canada would not be a place of medical tourism to seek assistance in dying. Age of adult is 18. Grievous and irremediable medical condition is direct out of the Carter decision. and again, makes a voluntary request for medical assistance in dying, and that the patient has been given informed consent after being given all of the information they need, including means available to relieve their suffering, including palliative care. I think amongst the palliative care community, there were concerns there would be a mandatory requirement for palliative care consultation, which of course would absolutely cripple the delivery of palliative care services, but it simply they need to be informed. The criteria around grievous and irremediable were further modified by this 4-part definition, which is not in the Carter criteria or Carter decision, and it says that the grievous and irremediable means that it is an incurable disease, illness, or disability, that you need to be in an advanced state of irreversible decline in capability, and that you're experiencing physical or psychological suffering that cannot be relieved through means acceptable to you, the patient, and that death is reasonably foreseeable. Just to say that nobody can look to see a legal definition of reasonably foreseeable. The Canadian Medical Protective Association has suggested 6 months. I anticipate there will be continuing lawsuits challenging this, and we'll probably have some better legal definitions, but we have that sort of vagueness. If you go to the government website and say, what does this mean? They say that medical assistance in dying is not death on demand. It is reserved for those who are really declining towards their natural death, allowing them to option a peaceful death as opposed to something that may be prolonged or difficult to them. And it recognizes both patient-administered, or so if you like, self-administered methods, as well as the physician-administered, or sorry, medical administration. And just to put it in context, in Quebec, it is only the IV route that is available, and in Oregon, it is only the oral route available to the patient. So there is differing programs around the world. So why are we here? Well, patient autonomy has a very high value in our society. Having said that, it is not absolute, and there's still an ethical and professional obligation on the physician to make sure that the safeguards are adhered to, and that the vulnerable who have a right of life have those safeguards considered. So the Carter decision talked about the fact that free and informed consent could be a good way of approaching this. So what does that really mean? That the physician, or nurse practitioner, as the case may be, really has to ask themselves, is this patient really making this decision on their own? Is this an individual who may be subject to coercion, manipulation? Do they live in an environment where their domestic or life partnership may be one of violence? Are they economically disadvantaged? Are they doing this because they're worried about being a financial burden? And these are the kind of constructs that we expect the people doing the assessments to bring to the bedside, because again, this isn't death on demand. This is there are criteria, and you need to make sure that this is free and informed consent. So we expect physicians to explore what's the social network of the patient, what are the values and beliefs of that individual, what's really important to them, and how have they really considered those palliative care options when they come to their own decision making. If you look at the Oregon experience, where they have the Death with Dignity Act, they have over 300 peer-reviewed journal articles relating to the experience of assistance in dying in that jurisdiction. I hope we can do the same in Canada. Public reporting and scientific reporting is important, and I'm certainly comforted by the fact that in Oregon, the people who seek assistance in dying are typically people who are well-educated and have a cancer diagnosis. I have some comfort in knowing that people are not being marginalized and potentially being discriminated. Just briefly, the importance of a medical record, I think everybody knows about that. Documentation is really important, and I just direct you all to the college website. We have standards around that. The process does require 2 opinions, one either from a medical practitioner or a nurse practitioner, and at the request of the ministry, we have allowed one of those assessments to be by telemedicine. I think this was really an important aspect around reaching out to rural, remote communities. There is a requirement that the telemedicine consultation be attended to by a regulated practitioner. We appreciate that's a bit of a barrier, but again, we think the importance of making sure that there's no coercion, that there's truly free and informed consent is there through that process. And there are expectations around things being independent and being witnessed by two people. The person, again, has to be competent and maintain competence throughout the process. There is a requirement for a 10-day reflection period. We don't want people to be making rush decisions. And having said that, though, this reflection period can be shorter if the clinical circumstances indicate that death is perhaps more imminent than that, or they may lose capacity. And there is a requirement the patient reconfirm their consent prior to the administration. Again, medical record, very important. There will be complaints, and I say that as somebody who looks at lots of complaints every year, but we get complaints as it is regarding good palliative care. And I appreciate all the palliative care providers who've had to respond to complaints that are registered with the college, but inevitably there's a daughter from California who flies in at the last minute and believes that all of the decisions that mom's making are wrong and people have done things. So a good record is your best defense in what will be, I'm sure, difficult times. Just to say that from the process in the province, the medications are dispensed by the pharmacist to the provider, not to the patient. The pharmacist becomes a friend of the practitioner, if you like. There is a pre-printed order. Drug coverage is assured by the ministry. There is an expectation that 2 doses of the medication will be dispensed, with the provider then returning any unused medications to their pharmacy, be that hospital or community. And there's an expectation that the practitioner will stay with the patient until death is confirmed. There are a whole bunch of provincial documents, and I won't go into all of those except to say that these are administrative documents. They're not sourced in law, but they are tied back to the professional standards. And where to send the forms, health authority, if it's a health authority patient, and the coroner. And just to touch upon the conscientious objection. Again, college expects physicians to respect patient autonomy, the process of informed decision-making, and to not be abandoned. When we talk to physicians about this, we recognize and respect conscientious objection. And in exchange for that, we do remind physicians that even though you are a conscientious objector, your patient still has a right to information, not the assessment, information. And you must give them enough information for them to be able to make some informed decisions. If that includes seeking an assessment for medical assistance in dying, then your role as a practitioner is to not abandon care, to assist them, and then transfer their care. But we have not said that you need to refer them, and that's quite different than the province of Ontario, where that referral requirement is there. So happy to turn it over to Doris.